Okay, for this topic, we're going to be covering speech audiometry. Let's go over our objectives here. We're going to be able to name the components used for speech audiometry and the different ways speech can be delivered through the audiometer. Describe how the speech channel is calibrated according to ANSI S3.6 standards. Describe how to use the volume unit meter, to calibrate the input level and discuss why this must be done for each speech test and for each patient. Describe different methods of performing a speech recognition threshold test and how to interpret results. Describe the difference between a speech recognition test and a speech detection or awareness test. List different types of materials that might be used for a speech recognition test and a speech detection test. So objective number 6, describe how to perform a test for word recognition and score it, and discuss issues related to selecting the presentation level for testing. Define what PB max is and discuss strategies for obtaining PB max. List the types of materials typically used to obtain a word recognition score and discuss the differences between whole word and phoneme scoring, as well as half list versus full list testing. Be familiar with how to obtain a patient's most comfortable loudness level and uncomfortable loudness level. Define what is meant by the speech banana and explain the general distribution of speech sounds as to frequency and intensity characteristics. Describe how different degrees of hearing loss would affect a patient's understanding of speech. Objective 10, explain what is meant by the speech intelligibility index. Understand how to use a count the dots audiogram to help a patient understand their hearing loss and how it might be applicable to different degrees of hearing loss. Describe the computer-assisted speech perception assessment and discuss this test's advantages. And graph the performance by intensity function for phonetically balanced words for cochlear versus eighth cranial nerve disorders and calculate their respective rollover ratios. We want to be able to calculate word recognition scores using whole word scoring and phoneme scoring, as well as determine whether two scores are significantly different from each other based on the critical differences from the binomial distribution. Demonstrate familiarity with some speech and noise tests, and discuss variations that are used for speech testing in children. So just starting off, introduction, what is speech audiometry? It is basically a type of audiometry used to assess how well a patient is able to detect and or recognize or specific types of speech stimuli. You can have patients with identical audiograms, but they might have differences in their superthreshold speech recognition abilities. Superthreshold meaning above threshold, so basically not at detection threshold like we have pure tone audiometry, but superthreshold meaning at an audible level, like a conversational level as an example. I want to talk about speech audiometric testing and how it might contribute somewhat to differentiation between cochlear and eighth nerve disorders to some extent. Cochlear loss has predictable relationships with the audiogram and word recognition testing, and it's that predictable relationship that we can exploit in helping determine who might be at greater risk for cranial eighth nerve disorders. And speech recognition results may be used to compare against the audiogram between the two ears or across different points in time longitudinally. So speech recognition may be used to help in establishing hearing aid or cochlear implant candidacy, or it may be used to compare aided versus unaided test results, looking at the benefits of hearing aids or the benefits of a cochlear implant or implants. There are two basic types of speech audiometric testing. Both types of tests can be performed in quiet and in noise. We have a speech threshold, so the detection threshold or recognition threshold. And we also have superthreshold speech recognition abilities, often termed word discrimination or word identification. And we often score that in percent correct for speech recognition testing. But there are other ways to score it when you're talking about speech recognition and noise. The key components here for speech testing with an audiometer, it's same as it is with pure tone audiometry, but we have additional inputs here. We have the microphone, a CD, or a computer, which is going to play the speech audio, which is going to output speech audiometry materials, and then we have an input volume adjust, input level adjustment to make sure our volume unit meter is hitting 0 VUs. We want it to hit 0 VU so that we know that the dB level set to the audiometer is what the actual dB level being presented to the ear is. And then we have the audiometer attenuator dial that I mentioned a moment ago, that we can set the dBHL level, and then we know that as long as we're hitting 0 VU on the VU meter, we know that dBHL level is being presented to the earphones appropriately. So we have microphone, CD, and computer. Microphone would be monitored live voice, where we're speaking the speech inputs. CD, a recording on a CD, or WAV files or MP3 files, recordings from a computer. Recorded materials are preferable over monitored live voice due to consistency and standardization. It's easier to compare across ears, across sites, across testers, over time. The benefit of monitored live voice is that it's more flexible than recorded materials. So just as an example, say we're doing a speech recognition threshold test and we want to eliminate certain words that are not in the vocabulary of a non-English speaker. We can do that very easily using monitored live voice presentation. Same thing with very young children. We can use just a very limited set of words for a speech recognition threshold. It's much easier to do it monitored live voice than it is for a recording where we have less flexibility. There are other benefits to monitored live voice. We can also perform audio-visual perception testing if you want to give visual cues to the patient. There are recordings that are audio-visual, but most recordings are audio only. There are a very limited number of audio-visual recordings. So for speech testing, we want to talk about how we calibrate the equipment. We use the ANSI reference level for speech audiometry to calibrate a pure tone 1000 hertz pure tone through the speech channel, and then the speech output is set 12.5 dB higher than the 1000 hertz Retzbull. The Retzbull is the reference equivalent threshold sound pressure level. It's just a conversion factor that lets us go from dB-SPL to dB-HL. So that's what a Retzbull is. It just moves from dB-SPL that you've talked about in acoustics class to dB-HL, which we use with the audiometers. And when we calibrate for speech, we're adding an additional 12.5 dB correction factor for speech, because that's related to the crest factor for speech, which is basically the difference between the RMS average amplitude for speech and the peaks of speech. So in the Retzbull, conversion factor is going to be specific to the individual transducer. So we have two transducers listed in this table here. We have the TDH39, which is a supraoral headphone, and we have the insert earphone, the ER3A, and you can see that they have different 1000 hertz Retzbulls, but they have the same speech correction factor. So what we would do is take the sound pressure level that we're presenting at, measuring, say you were measuring with a sound level meter in SPL, and then we would add the Retzbull, say 7 dB for the TDH39 or 5.5 dB for the ER3A, and then we'd add an additional 12.5 dB correction factor. So for calibration, the total correction factor for speech for a TDH39 headphone is 19.5 dB, and for the correction factor for an insert earphone is 18 dB. So if you were measuring with a sound pressure level meter and you wanted to convert from dB SPL to dB HL, then you would use these conversion factors. I'm sorry, if we're going from SPL to HL, we would subtract the conversion factor. If we're going from HL to SPL, we would add that calibration conversion factor. So just to, again, the reason where that 12.5 dB came from, it came from the difference in amplitude between the average level of speech, the RMS average, and the peaks of speech, which is about 12 dB. So again, the 12.5 dB correction factor for speech comes from the difference in speech average versus speech peaks, which is about 12 dB. That's just illustration, and the speech map here is just to show you the difference in amplitude between average speech and speech peaks. We need to adjust input levels such that the 1000 Hertz tone peaks near 0 VU. Otherwise, the dBHL value you have selected with your attenuator dial will not be accurate. Additional sources of variability come from monitored live voice presentation, like the distance that you are from the mic, the variation in your vocal effort from average vocal effort to raised vocal effort. Additional sources of error with recorded materials come from the external source, like if you have it coming from a computer, do you have an equalizer set inadvertently? Accidental manipulation of the output level control, like the volume control on the computer. So those are additional sources of error with recorded materials that you may not always realize. Each CD or set of recorded materials has their own calibration tone, so you should always calibrate for the recorded materials prior to the test. That is distinct from audiometers that have wave files built in or audiometers that have speech files built in. They will not require calibration, but if you have an external audio source like a CD or a computer that you're outputting into an audiometer, you should calibrate before each day or before each use. Calibration with monitored live voice is simply presenting stimuli, words, for example, with the adjustment of mic sensitivity so that the peaks of your speech hit 0 VU on the VU meter. The lowest level at which patient can produce desired response to speech stimuli is the speech threshold. The speech threshold may be used as a cross-check against the audiogram. While speech spans a bandwidth in excess of 8,000 Hertz, speech thresholds typically represent frequencies where patients' hearing is at its best. For example, speech threshold is usually equal to or better than the pure tone average at 500, 1,000, 2,000 Hertz. It's usually within about 6 dB, usually better than by about 6 dB, but plus or minus 6 dB most of the time. Speech recognition thresholds utilize two-syllable equal stress words called spondees or spondaic words. So again, they're two-syllable, equal stress on each syllable. Pancake, baseball, hot dog, airplane. Equal stress on each syllable. The VU meter should peak at 0 VU for each syllable. The word lists are based on the CID W1 word lists of 36 spondees. Those are sometimes narrowed down to a smaller word list for children or streamlined for adults. The sentence materials may be used, but far less frequently. I've never seen sentence materials used for speech recognition thresholds. It's primarily spondee words, other than pediatric variations where you might use body parts. Tester may vary the intensity of the words to find the lowest level at which 50% correct is obtained. And by varying intensity, I mean adjusting the audiometer attenuator dial. There's no major difference between monitored live voice and recorded materials for speech recognition threshold. That is in stark contrast to super threshold word recognition testing, where there is a major difference. I mentioned those 36 W1 spawn D words can be narrowed down. Here's an example. There's 15 that are the most homogeneous in audibility. So toothbrush down to padlock. So those are going to be the most similar to one another in terms of audibility. So hence why that's been streamlined. Then we also have the 20 most easily pictured. That's for pediatrics, going from cupcake down to seesaw. Now you might be wondering, why does homogeneity matter for audibility? And the homogeneity matters because we want each stimulus to have the same probability of identification as another stimulus. We don't want easy words versus hard words. If we're trying to perform a test to find the recognition threshold, we want them all to have the same probability of being recognized. As far as why does most easily pictured matter, we want, for a child who's performing the speech recognition threshold test, we want them to be able to, we don't want them to be hung up on the picture, the ability for the word to be pictured and for them to be able to recognize that picture. We want them to be only tested on their ability to auditorily recognize that word, not their ability to visually recognize it. So we want them to be easily pictured, equally easily to be pictured. It would be ideal. But that hasn't been tested per se. So here's an example of some of those pictures: hot dog, baseball, ice cream. I know ice cream is 2 words, but for our purposes it's considered a spawn D. Toothbrush, rainbow, popcorn, snowman, cupcake, airplane, French fries, again, two words, football rather, and bathtub. Speech recognition threshold, when we're trying to assess it, we want to familiarize the patient with a list of words first. Those words that are unfamiliar or that cannot be verbally produced should be omitted. That's what I was talking about with monitored live voice being easier in some respects. If they can't verbally produce a certain word, or if they're not familiar with a word, like a child, then you may want to omit it from the test and use monitored live voice. Carrier phrase is not typically utilized. I haven't really mentioned what a carrier phrase is. That's like, say the word hot dog, say the word baseball. We don't usually use a carrier phrase. We just say hot dog, baseball, airplane. There are different types of procedures that we can use. There's some ascending procedures where we're going up in intensity. There are descending procedures where we go down in intensity. And we'll go over a couple of different procedures for measuring the speech recognition threshold. Here are some sample instructions. For your first speech test, you will hear some 2-syllable words like sunset or airplane. Please repeat each word you hear, even if you have to guess. Some of these words will be too faint to hear, but try to repeat as many as you can. Do not be concerned about missing some of the words, since it is expected that this will happen. That's just an example of instructions you can use. So the speech recognition threshold can be performed monitored live voice with speech syllables peaking at 0 VU, or with two widely used recorded lists. There's the Audiometry of St. Louis list and the Department of Veterans Affairs list. Most are the CID W1 or W2 lists, typically the W1 list. ASHA has a list of 15 recommended words to use with familiarization and preceding testing, and it was that list that I showed you earlier, those homogeneous words. That's the same as the ASHA list. And SRTs using monitored live voice and recorded materials should be comparable, but the chosen procedure, ascending versus descending, that makes a difference. And example instructions, here's another set of example instructions. I guess I've got 2 sets of examples. I'm now going to find the softest level that you can recognize some common words. Please repeat the words that you hear, even if you have to guess. So just another set of instructions you can use. These are fine too. Spondee's SRT or Spondee's speech recognition threshold is the lowest level that the patient can recognize at least half of the time. Spondee SRT usually begins with a familiarization of the list of the words at a comfortable listening level, so words unable to be identified are omitted from the test list. I already mentioned that. Okay, now so let's get into one of these methods here. The Downs-Menard method actually has some historical legacy back to WSU. This is one of our former, now deceased clinical educators or professors, David Downs, and one of his students, Menard. They created a procedure where you familiarize the patient with the spondees at a comfortable level. You instruct the patient on what you're going to do, as we've already mentioned the instructions. Then you begin presenting spondees at the lowest audiometer setting. So starting maybe around 0 dBHL as an example. You ascend in 10 dB steps until one word is repeated correctly. Then you decrease the presentation level by 15 dB. This is the start level. Then you present spondees at start and count the number correct or incorrect. You stop when you get 2 correct, or you increase by 5 dB on the attenuator when 3 are incorrect at a given presentation level. So the threshold is met when you get 2 correct at a given presentation level, and you increase it by 5 dB when you get 3 incorrect. That's the gist of the procedure. So here's a pictorial representation of this procedure. I do have the article in the supplemental materials on Blackboard if you want to read it. It's a pretty easy read from the hearing journal. Instruct the patient, you familiarize the patient, you ascend in 10 dB steps from 0 dBHL or 30 dB below the estimated threshold if they have a previous threshold, giving 1 word per step until you get 1 correct. Then you subtract 15 dB to find your starting level for the test series. Then you present 2, 3, or 4 spondees at the starting level in 5 dB increments until 2 are correct. There's just a pictorial graphic on how that would work out in realistic fashion. You'd be drop 30 dB from their estimated SRT, and then you're presenting at a given level. In this example here, your start level, 3 incorrect, then you go up 5 dB, 3 incorrect, you go up 5 dB, you get 2 incorrect, 1 correct, 1 incorrect, so you got 3 incorrect, go up 5 dB, 1 correct, 3 incorrect, go up 5 dB, now you get 2 correct, and that is your threshold. There's another procedure called the Martin and Dowdy method. I've seen different years associated with it, 1978 versus 1986. That's neither here nor there. This is basically like a up 5, down 10 procedure that you use with the modified Houston-Westlake with pure tone audiometry. You familiarize the patient with spondees at a comfortable level. You instruct the patient. So far, so good. You present 1 spondee at 30 dBHL. If the word is not repeated correctly, then you go up 20 dB to 50 dBHL, and then you decrease in presentation level by 10 dB for each correct response, and increase by 5 dB for each incorrect response. You stop when you have found the lowest level at which 3 words are repeated correctly. It's pretty straightforward. 3 out of 6 words is what you're shooting for. Maybe a little bit slower than the Downs-Menard method, but a little bit more intuitive possibly because it's the bracketing up 5, down 10 procedure. So here's a breakdown of 3 different methods. I've got the Martin and Dowdy method, 1986. I've got the Downs-Menard method, 1996. And then I also have the ASHA 1988 guidelines. These ASHA 1988 guidelines are the newest form of ASHA, the ASHA method. It's still considered the recommended ASHA procedure, but it is not widely used. Starting intensity level for the ASHA method is 30 to 40 dBHL above the estimated SRT or at the pure tone average. It employs either 2 dB steps or 5 dB steps, using either 2 words per step or 5 words per step. And then the level at which the patient recognizes the material 15%, 50% of the time is calculated mathematically by the Spearman-Carber equation. We won't go into great depth on the ASHA method. It's a little overly complex for what this procedure needs to be. I would stick with either the Martin and Dowdy method or the Downs-Bernard method. If you want me to go into greater detail on the ASHA method, just let me know. Schlock did demonstrate, Schlock 1996, et al. 1996, demonstrated that the direction of the threshold search, ascending versus descending, significantly affects PTA-SRT agreement in patients who are feigning hearing loss. When an ascending SRT procedure was paired with a descending pure tone procedure, the PTA-SRT discrepancy was maximized at 40 dB, so making functional hearing loss easier to detect. That's using an ascending SRT procedure, such as the Downs-Bernard method, with a descending pure tone audiometry procedure, starting at a higher level, going down. That maximizes the discrepancy between PTA and SRT. Usually you don't want a discrepancy unless you're trying to find someone feigning hearing loss. So if there's a greater than 10 dB difference between the SRT and the PTA, then you want to explore other reasons. I mentioned 6 dB is pretty common for agreement, but 10 dB is at the upper limits. If there's greater than 10 dB difference between the SRT and the PTA, explore reasons why. Is it the shape of the audiogram? If it's a steeply sloping audiogram, you might use a Fletcher pure tone average instead of the conventional 3-frequency pure tone average. What is the Fletcher pure tone average? That's using the best 2 frequencies out of 3 for 500, 1000, and 2000. So that's usually 500 and 1000. Sometimes you'll get better agreement with the SRT using that Fletcher average. If there's limited English proficiency, their SRT might be significantly worse than their PTA. If the developmental age is off, with low IQ, for example, you might have chosen the wrong spondee list. Maybe you've chosen the adult list when you should use a pediatric list. Is there a calibration error on your part? As I mentioned, the types of calibration errors in a previous slide. Are they exaggerating their pure tone thresholds? That would be having a PTA that's much worse than their SRT. Is there confusion between stimulus presentation and tinnitus perception? So re-instruction required. Is there eighth nerve disorder or just poor word recognition score in general? If a person has a poor super threshold word recognition score, they might have a PTA that's much better than their SRT. So here's a breakdown of agreement. I said within 10 dB typically, but if you want to classify it into good agreement, fair agreement, and poor agreement, plus or minus 6 for good, plus or minus 7 to 12 for fair, and greater than equal to 13 dB for poor agreement. Now moving on to the speech detection threshold, aka speech awareness threshold. This is the lowest level that someone can simply detect the presence of speech, like pushing the response button when they detect the presence of speech. It's usually at least 5 to 10 dB lower than the SRT. It relies on the frequency with the best sensitivity. I had a patient the other day where his speech detection threshold was much better than his pure tone, his best frequency that I tested, and it happened to be that his best frequency was 125 hertz, so I had tested 125 hertz in that case, and then it matched up just fine. He had kind of a corner audiogram. So these are Erber's auditory skills hierarchy. This is good to be aware of in general. Detection, discrimination, identification, and comprehension, going from the lowest auditory skill to the highest auditory skill. For speech threshold, we typically use detection, which is the lowest auditory skill, and identification, which is synonymous with recognition, which is the second to highest auditory skill. Comprehension is more related to speech-language pathology. And then discrimination, we just typically don't use that. That would be telling the difference between two syllables or two words that have phonemic pairs. So the SDT is only used when the SRT cannot be obtained. So adults with severe to profound hearing loss, young children with speech and language deficits, patients with severe cognitive impairment. Speech material type or list is less crucial with speech detection threshold testing. If you're into pediatrics, you might just use ba 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 ba, ma ba 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 ba. You might use syllables, nonsense syllables like that. Familiarization is not required with an SDT. You'll typically bracket up 5, down 10 if you're working with adults. If you're working with very young children, you might bracket up 10, down 20. SDT should be in reasonable agreement with the best pure tone threshold. It should be within 20 dB of the best 2 frequency average. It only represents the best hearing frequency. And in the sound field, like with pediatrics, it isn't ear specific. So I'm thinking of visual reinforcement audiometry in the sound field. Now moving on to word recognition score. The SRT is useful for both describing hearing loss, degree of hearing loss, and as a cross-check for the audiogram, but the SRT does not represent conversational speech recognition abilities, nor does it represent maximal speech recognition abilities. Conversational speech is around 40 to 50 dBHL, depending on the transducer you're using, supraoral headphone, circumaural headphone, insert headphone. If you're using an insert, it's closer to 50 dBHL. If you're using a supraoral or circumaural, it's closer to 40 dBHL or 45 dBHL. Intensity of speech is dominated by vowels, which carry the greatest energy. The dynamic range of speech is around 30 dB. This is important. These are important little facts to know. Testing above SRT is called suprathreshold testing. I've already commented on that. First, what is a phoneme? Let me break that down. That's the smallest abstract unit of sound in a language that distinguishes one word from another word. Minimal pairs would distinguish one word from another word by a single phoneme. Pair and bear, for example. Voicing is the only thing that distinguishes those two. The single phoneme P versus B, and that's reflected by differences in voice onset time. The word recognition score is a routine part of audiologic testing. It involves phonetically balanced word lists, such as the CID W22, or phonemically balanced lists, such as the ANU6. They sound the same, they're slightly different. Either way, they're called PB words. Whether you want to use that for phonetically balanced or phonemically balanced, they're PB words, and our search for the best score is called PB max. Oh, let me give you a little bit of a breakdown here. Developed by the CID, Central Institute for the Deaf, as a modification of the original Harvard PB50 lists, the goal of phonetic balance is to mirror the natural distribution of speech sounds as they occur in everyday discourse, English discourse. Phonemic distribution, instead of sampling general running speech, the lists are balanced based on the frequency of phonemes within the specific domain of English monosyllabic words. So a little bit of a difference between the two, not a huge difference. A linguist might argue differently. So phonetically balanced, the W22s, the concept is to match the natural frequency of speech sounds found in everyday running speech and text. The pros, high real-world realism, captures a natural baseline of everyday listening. Cons, variable word structure, introducing minor difficulty differences between lists, only supports binary whole word scoring. So is the word correct or incorrect? So I mentioned you can do phoneme scoring. You have to do that with phonemically balanced lists like the NU6. The concept is you matched the frequency of individual phonemes is restricted to a specific word structure, consonant, nucleus, consonant, CNC, otherwise known as CVC, consonant, vowel, consonant. The pros, perfect mathematical equivalence across all lists, enables phoneme scoring, tripling the data points, 150 units per 50 words, for higher reliability and more precise error analysis. The cons are that it's an artificial constraint. Real speech doesn't happen only in isolated CNC monosyllables. Each full list is 50 words, and a half list is 25 words. That's the general standard. 25-word lists are far more common than 50-word lists. 50-word lists are the gold standard. It's scored correct, incorrect at the word level, but sometimes lists like the NU6 can be adapted to score at the phoneme level. There will often be a carrier phrase like say the word fish, say the word laud, say the word hike, that kind of thing. The format is most often open set, so you wait for a verbal, or in some cases a written or typed response. Some word lists are closed set, where they have maybe 4 words to choose from, but they're not commonly used clinically. It's important to keep in mind that the list size, n equals 25 or n equals 50, is directly related to the variability of the test outcome. Using a longer list takes more time, but it decreases variability. Phoneme scoring can be a compromise, but it's not widely utilized yet. In the future, it may be. Regardless, it's important to report the word list used, the method of administration, the list size, ideally the scoring method that's not commonly reported. Occasionally, I've used phoneme scoring, and I'll report phoneme scoring if I do. If they don't report the scoring method, it can be assumed that they're using whole word scoring. One criticism of the NU6 is that some items are more difficult than others, hence the creation of a variation of the NU6 called the NU6 ordered by difficulty version. Most difficult words are placed first. If a patient gets 0 to 1 incorrect, they can stop at 10 items. If they have no more than 3 wrong, they can stop at 25 items. If they have 4 or more words wrong, they have to do the full 50-word items. That's a compromise. So let me break down some common word recognition tests to be aware of. The first one is not the most common, but it is used with cochlear implant candidacy. The CI-CNC word list. It's open set. It's used for cochlear implant candidacy, isolates peripheral spectral resolution, dictates FDA insurance candidacy, tracks post-op progress for cochlear implant candidates. The Maryland CNC, also open set. This is mainly exclusively used for veterans' VA compensation pension exams. It's a standardized acoustic hurdle required strictly for VA CMP legal disability ratings. Also of note, it's one of the few times where you'll have 50 words mandated to be used instead of 25 words. You have the CCT, the California Consonant Test. This is a closed set test for adults with high frequency sloping loss. The idea is to evaluate high frequency consonant confusions, to unmask the guesswork in hearing aid validations. This is an older test. When I say it's an older test, I don't mean it's older than the NU6 or the W22s. It's newer than that. It's older and no longer researched. We actually use it in our clinic, Hearing Life, but we use a modified version of it that's open set, and we don't use it in the way that's originally intended, so it doesn't have the same validity. We have the PBK50s, which are an open set word recognition test used for pediatrics, 4, 5, and 6 years old. Standard open set repetition, adjusted downward for early childhood vocabulary. So we're just using vocabulary of a kindergarten child. Then we've got the WIPI, word identification by picture identification. This is a closed set test, and you have pictures that the patient is pointing to for age 3 to 5. So evaluates speech identification by picture pointing, completely removing the hurdle for verbal expressive language issues. They can just point to the response. Selecting the presentation level. There's no single agreed upon approach. Over the years, there have been many levels that have been chosen, but it depends on the question you want to answer. So if you want to answer, what is the performance at a normal conversational level, you might pick 40 to 50 dBHL. But if you want to answer, what is PB max, what is the best score they can achieve regardless of intensity level, you're going to pick a high intensity level so you can maximize audibility. Normal hearing listeners reach PB max at 30 dB SL, aka 30 dB sensation level, aka 30 dB above the SRT or pure tone average. But that's not true for cochlear hearing loss. That's true for normal hearing listeners. So back to selecting the presentation level. So usually it's a little safer to use 40 dB above the SRT or 40 dB SL. That's a little safer choice, but this is only used for PB max for relatively flat cochlear hearing losses. It might also be reasonable to use for conductive hearing losses in normal hearing, 30 to 40 dB SL. While Brandy 2002 from their textbook recommends using 40 dB above the pure tone average, using a little bit different pure tone average of 500, 1000, 2000, 3000, 4000, there is newer evidence available that is probably more evidence-based than what Brandy's recommendation is. Let's briefly talk about most comfortable loudness and uncomfortable loudness levels because they will come up. We'll come back around to selecting the ideal presentation level for PB max, but let me take a detour here to talk about most comfortable and uncomfortable loudness levels. The level a patient prefers to listen to speech at is their most comfortable loudness level. And the level that is too loud is their uncomfortable loudness level. Pretty straightforward. Typically, the most comfortable loudness level bisects the speech recognition threshold and the uncomfortable loudness level. Some form of categorical loudness scaling is the most reliable way to obtain MCL and UCL. Categorical scales may vary depending on the test or the creator. I'll show you what I mean by that. Here's an example of a categorical loudness scale. So you've got a list in front of a patient going from very soft to uncomfortably loud. The key to this is you have numbers associated with the descriptors. And this is used not only in hearing aids, but also in cochlear implant settings. They might just use different variations of the same thing. But categorical loudness scaling is a tool that we want to use for measuring most comfortable and uncomfortable loudness levels because it produces better reliability. This particular list is used from the Cox contour test, and it is a widely used variation. UCL represents the upper range of hearing and may be useful in making sure hearing aids or cochlear implants are not set too loud. MCL has less clinical relevance and is considered a range rather than a single level. It's useful for aided testing with a hearing aid or cochlear implant to make sure average speech is at a comfortable level. So here's an example of dynamic range. I mentioned SRT, I've mentioned MCL, I've mentioned UCL, I've mentioned for normal hearing individuals, MCL typically bisects SRT and UCL. We can see that here. We do see a compression of loudness occurring for cochlear hearing loss, where we don't have a big difference between MCL and UCL. We have a very small difference. This is called loudness recruitment, or another term might be softness in perception. We see that to some extent with conductive hearing loss, but not nearly as much. Mainly the limits to UCL with conductive hearing loss are equipment limits. For normal hearing listeners, MCL is about 40 to 55 dBHL, and UCL is about 100 dBHL. In reality, UCL might be a little bit less, like around 90. The difference between the SRT and the UCL is the dynamic range for hearing for an individual. In sensorineural hearing loss, we often see elevated SRTs with unchanged or slightly elevated UCLs, making the dynamic range more narrow. Strategies for obtaining PBmax, back full circle again. One of the most straightforward ways to obtain PBmax is to find the UCL and drop it down by 5 dB. That's your safest bet. Since phonemes have different intensities and different frequency ranges, and the dynamic range for speech is around 30 dB, we want to maximize audibility to find PBmax. Here's an example of a speech banana. The shaded region, the speech banana, represents the normal distribution of conversational speech. It's helpful to overlay the audiogram on top of the speech banana, or rather the speech banana on top of the audiogram, for audiometric counseling. We can see where the different speech sounds or phonemes in American English fall in the audiometric range. Some of them are softer than others. Some are louder than others, like the vowels. Some are high frequencies, like fricatives, especially voiceless fricatives. So strategies for obtaining PBmax. This audiogram also categorizes phonemes into acoustic phonetic categories like vowel formants and manner of articulation. Just another way to categorize it. Speech perception is often affected by vowel formants, co-articulatory cues, so the relationship between adjacent vowels and phonemes, or consonants rather. Voicing, gender differences. You've probably talked about things like vowel formants, co-articulatory cues, and voicing in your undergraduate phonetics class, I hope. This figure shows how two different hearing losses could affect the audibility of the different speech sounds presented at a relatively normal conversational level of 50 dBHL. Even with a mild high-frequency hearing loss, you can see that many of the high-frequency components of consonant sounds like F, S, TH, T, Z, V would be inaudible below the patient's thresholds and might cause some word confusion, such as in flight versus sight. Of course, different degrees and shapes of hearing loss will result in different acoustic features being audible to the patient. In this figure, we can see how much more acoustic information is available to the patient when we test at UCL -5 compared to 40 dB Ray SRT. So comparing 65 dBHL on the left for a presentation level, comparing it to 85 dBHL on the right, you can see that we have far more acoustic information audible to the patient on the right-hand figure, indicating we have a higher chance of reaching PBmax. There is another way to obtain PBmax that works for 2,000 hertz thresholds that are less than 50 dBHL, or 2,000 hertz thresholds that go up to 75 dBHL. If they exceed 75 dBHL, then you should just stick with the UCL -5. But you can see that as you move up in intensity on your 2,000 hertz threshold, as you move up, you're adding less and less sensation level until you get up to about 85 dBHL as your max presentation level for 75 dBHL threshold at 2,000 hertz. Above that, just use UCL -5. Let's talk about the Speech Intelligibility Index. Using the Speech Banana in the clinic is helpful visual counseling tool, but it's not an objective quantification of how hearing loss affects audibility in real-world speech. The earliest attempts to quantify the percentage of speech audible based on the audiogram were variations of what are called the articulation or the audibility index. Today, the version we use is the Speech Intelligibility Index, which is a more complex version of that. There have been many versions of the articulation index over the years, so while using the Speech Banana in the clinic is a helpful visual counseling tool, it's not an objective quantification. Oh, I got a slide that's a double there, so we'll skip over that. So here we want to show you a couple diagrams here. Here we see two hypothetical plots demonstrating the relationship between Speech Intelligibility Index and a flat hearing loss. In another plot that's on the left, Speech Intelligibility Index drops as the flat hearing loss increases, and this is a reverse ogival curve or a sigmoidal curve. On the right side, we have a ogival curve. On that right side, we see the relationship between Speech Intelligibility Index and hearing loss. I'm sorry, let me rephrase that. On the right side, we see the relationship between word recognition score and Speech Intelligibility Index, but it is represented by an ogival function, just like an S-shaped function. So you can see that as Speech Intelligibility Index goes up, word recognition score tends to go up as well. Here is a visualization of the band importance functions for the Speech Intelligibility Index. So what I'm trying to communicate here is that not all frequencies contribute equally to speech understanding. We have the quote-unquote speech hub between 1,000 and 4,000 hertz. That's where the mid to high frequency range is dominant, peaking sharply at 2,000 hertz. It carries nearly 80% of intelligibility because it houses crucial high frequency consonant cues. At the extremes, the low frequencies between 250 and 500 hertz, that carries the raw power and volume of vowels but offers little in clarity. In the very high frequencies, between 6,000 and 8,000 hertz, it offers the fine details of speech but contributes minimally to the overall score. The clinical bottom line is this data explains why typical high-frequency sensorineural hearing loss devastates speech clarity. Patients lose the critical 2,000 to 4,000 hertz range, and that dictates why hearing aids prioritize gain in these specific channels to maximize the Speech Intelligibility Index. The Speech Intelligibility Index may be calculated by your hearing aid or your real ear software, but the actual formula is too cumbersome for clinical use. It's simplified by paper and pencil calculations, and they can be easily performed as a count the dots audiogram. It's the simplest, but not the fastest method. So here's an example of a early count the dots audiogram by Humes, 1991. He placed 33 dots at octave frequencies from 250 to 4,000 hertz. The idea is you would count the dots above the audiometric thresholds and multiply those by 3.3, and that would give you the percent audibility for the speech intelligibility index at a conversational level. In this case, it was called the articulation index, not the speech intelligibility index, because it was the predecessor to the speech intelligibility index. Another variant here is, it's the same one. This is just an example on a different audiogram, but we're using, in this example here, I think I have this from a different image where they used 100 dots instead of 33 dots. Same idea. It's the number of dots above the audiogram contour on the right side. 60 are audible. 40 are audible, 60 are inaudible. So 40% would be your speech intelligibility index. Not sure why the 40 is on the left and the 60 is on the right. That should be reversed. Mueller and Killian created their own versions of the Count the Dots audiogram. That's where you get the 100 dots. And you can see the Count the Dots audiogram within your NOAA audiogram module. It just doesn't calculate the percentage for you. I don't know why. It should, but it doesn't calculate the percentage for you. This is just an audiogram that I plugged in here. And we have a speech intelligibility index of around, I'm sorry. I misspoke. Let me go back here. Let me rewind. I said this was wrong. It is the dots below the audiogram. The dots below the audiogram that you're counting for the speech intelligibility index. Not the dots above, the dots below. This is not backwards. You have 40% is the speech intelligibility index. 40%, it's the dots below the audiogram, not above. My apologies. So again, the dots below the audiogram here, we've got 21% below this particular audiogram, and that your SII is 0.21 or 21%. Here's a different audiogram that I plugged in for the Count the Dots audiogram. It's arbitrary, but for this audiogram here, our SII value is 48%, the dots that are below the audiogram. Here's another version of the Count the Dots. Well, this is not the Count the Dots audiogram. This is another version of the articulation index. This is Pavlovik's method, where he looked at the range between 20 to 50 dBHL for 500, 1000, 2000, and 4000 hertz. He looked at what proportion was audible in 5 dB steps. And here's a template that I created for this based on his method for the articulation index. We would have 25% because we're counting the decibels that are audible in that 20 to 50 dB range, and that is 30 decibels out of 120 decibels total that are audible, and that gives us 25% for articulation index. Here's another one that I have, another arbitrary audiogram. In here, 60 of the 120 decibels are audible, so that gives us an articulation index of 50%. In software that we use for Wheeler hearing aid verification, it's calculated for us automatically. And this is the modern speech intelligibility index. So in this particular example, we plugged in the audiogram. We have our prescription targets represented by the crosses, and we have our hearing aid frequency response represented by the thick purple line in the middle. And then we have our calculation in the bottom right corner. 59% calculation is for speech intelligibility index with the hearing aid on, and then without the hearing aid on, in the lower right corner, it's 37%. So if you use an AudioScan VeriFit, it will calculate this for you automatically. Most Wheeler verification equipment will calculate this for you automatically. So the SII is very useful for hearing aid comparisons, unaided versus aided, hearing aid 1 versus hearing aid 2, audibility of soft speech versus conversational speech versus loud speech. Remember, SII predicts audibility with good accuracy, but less so for recognition abilities. At high levels, retrocochlear hearing losses may see rollover or worse performance, and there can be a discrepancy with word recognition performance falling below SII. I'll skip this. This is just a survey on word recognition tests that were used. W22s and NU6s are both commonly used fairly equally as of 2015 most of the time. NU6 had a slight edge. Here's an example of something I want to show you regarding comparison of recorded versus monitored live voice speech. You can look at either the right ear or the left ear. It shows the same data from 16 patients. What we see here is the super threshold word recognition performance, both recorded, which is going to be the purple line, recorded, which is the red line, in the blue line, in the light blue line, sloping upward, and then we see monitored live voice, which is the solid purple line on the, or dark red line on the left, and the solid dark blue line on the right. What this is showing us is that monitored live voice word recognition is much less sensitive to differences between patients' ears than recorded materials. So if we want to see differences between patients in terms of their performance, we will see much greater sensitivity by using recorded materials rather than monitored live voice materials. Monitored live voice materials are relatively insensitive to differences across ears or across patients. Here I do want to show you a PI-PB function or a performance intensity phonetically balanced, phonemically balanced function to determine PB max for normal compared to cochlear hearing loss. If testing had only been done at 40 dB SL, PB max would have been underestimated in the cochlear hearing loss case. So we can see here for normal hearing individuals, 40 dB above threshold is more than enough. We can see that for 40 dB, if we go up here, 40 dB is 30 dB is well good enough, but 40 dB is perfect. For normally hearing individuals, we're obtaining PB max of 100%. But if we only went 40 dB up for cochlear hearing loss, it looks like 30 dB is threshold. 70 dB would be 40 up. We're not at PB max. PB max is a little bit higher up here. And then we also have an example below where we have a PI-PB function for a patient with cochlear hearing loss compared to one with an eighth nerve disorder that shows a decline in word recognition abilities at higher intensity levels, aka rollover. So we can see here the person with the eighth nerve disorder, they decline in word recognition abilities at high levels, whereas the person with cochlear hearing loss does not. And there is a formula, PB max minus PB min divided by PB max, that can give you the rollover ratio. Greater than 0.45 is historically been used to flag for eighth nerve tumors, but more modern analysis like fMRIs, ABRs, find that it lacks diagnostic sensitivity and it's associated with neural presbycusis. So rather than retrocochlear tumors, the predominant cause of word recognition decline or rollover at suprathreshold levels in older adults is cochlear synaptopathy and auditory nerve degeneration, sometimes called age-related auditory neuropathy or neural presbycusis. Coltlarts found that rollover and acoustic reflex testing played a minimal role in the decision to order ABR and were not deemed important in the search for retrocochlear disease in a screening efficiency analysis. Rather, retrocochlear tumor, the predominant cause of word recognition decline at suprathreshold levels in older adults, is cochlear synaptopathy and auditory nerve degeneration, aka neural presbycusis or age-related auditory neuropathy. I do want to mention briefly a test that the textbook measures called the Computer-Assisted Speech Perception Assessment. It is not widely used, but it is a novel idea. The idea is to perform a PI-PB function using phoneme scoring with 10-word lists at multiple levels in a short amount of time. It was a good idea to establish a PI-PB function, but it never took off. Probably because of the price or because lack of familiarity with the test. So steps for obtaining word recognition scores: select the presentation level based on the question being asked. If you're using the CASPA, you can use multiple levels. You can use 40 dB Ray SRT for normal hearing and conductive impairment. You can use the DBSL Ray 2000 Hz threshold method for thresholds up to 75 dBHL. Other than that, for higher levels, use UCL -5. Present one or more lists and score. You can use phoneme scoring if you want. You can use ordered by difficulty whole word scoring if you want. Those are just options available to you, but they're not the most common methods. Consider testing at a second level when the score is less than 90%, sometimes at a lower level, because we know that rollover can occur even in normal cochlear ears because of neural presbycusis. Here are commonly used categories that are to generally describe word recognition test results. If they score between 90 to 100%, that would be excellent. 75 to 89% good. 60 to 74% fair. 50 to 59% poor. Less than 50, very poor. This is totally arbitrary. You'll find different categorizations of this. Don't get too hung up on this. For normal hearing and conductive hearing losses, we typically expect to see word recognition greater than 90%. For cochlear hearing loss, word recognition scores are variable, dependent on degree of hearing loss, audiometric configuration, and I don't have on here, but age. Age matters. For retrocochlear hearing loss and for older adults with neural presbycusis, word recognition score may be poorer than expected based on pure tone averages. These above statements are all generalities. The next topic I want to cover is critical differences in word recognition scores. So when is there a significant difference in word recognition scores between the two ears, or when is there significant change in the test over time? Or when is a patient better off with a hearing aid than without one? Is a word recognition score significantly better with one aid versus two, or with one hearing aid versus another? That's what we're going to use critical difference tables to look at. So any questions consulting these critical difference tables, they're on page 189 in Kramer. Note that word recognition score is modeled as a binomial variable, and so that variability is largest at 50% and its smallest near 0 and 100%. More generally, word recognition variability decreases as the number of items in the list increases. So as you move from 10 items to 25 items to 50 items, variability decreases. Here is a graphic from the original Thornton and Raffin paper that shows this representation of variability. We can see standard deviation on the y-axis. With standard deviation on the y-axis, you can see that as you move from 10 items to 25 items to 50 items, as you move a couple items you see here, you can see the curves are different in height. The fact that the 10 item curve is higher than the 25 item curve and the 25 item curve is higher than the 50 item curve indicates there's more variability there. They have greater standard deviations. The other trend you see on this graph here is the fact that you have 0 and 100% located on the left and 50% located on the right. So as we move towards the left, towards 0 and 100%, we have variability decrease. We can see it go down. As you move towards 50 on the right, we see all of these curves move up. So greatest variability around 50%, lowest variability around 0 and 100%. Why is variability lower around 0 and 100%? That's pretty straightforward. We're limited by the ceiling effect and the floor effect. You can't go higher than 100. You can't go smaller than 0. So there's a greater difference in 2 word recognition scores is required when using a 25-word versus a 50-word list in order to detect a significant difference with 95% confidence. So say you're looking, let me give you an example from the textbook here. Go ahead and pause the video while you retrieve your textbook and open up to page 189. What you'll see is you've got a list for 10 items, 25 items, 50 items, and 63 items. 63 items is just a 25-word list scored as phonemes. So what you'll see is a number on the left-hand column going from 0 to 49, and then on the right side you see a column going from 50 to 99. That's your first score percent correct. So let's pick one. Let's pick 10. So looking for 10% correct in that column on the far left on page 189. If you move to the right, you see that the score has to be 51% or greater for it to be a significant difference at the 95% confidence level using 10 items. Has to be greater than 33% for 25 items. Has to be greater than 25% for 50 items. Has to be greater than 23% for 63 items, which is again 25 words scored with phonemes. So that's an example on that page 189, critical difference tables. Let me give you another example here. Say I move down on this table to 30% on the far left column. If you're using a 25 item word list, you have to have a score that's greater than 58% for it to be statistically significantly different at the 95% confidence level. But if I use 50 items, it only has to be greater than 50%. So again, variability is greater with the number of items used. As mentioned, table 8.4 can be used to determine if 2 words or phoneme scores are significantly different from one another. Okay, moving on to differential diagnosis of cochlear versus eighth nerve cases. If suspicions of an eighth nerve tumor involvement are raised due to word recognition findings, and then further testing is warranted, could be, if you're doing it in your own clinic, acoustic reflexes and ABR, or it could be referring out to an ENT for an MRI, which is the gold standard. Honestly, the suspicions that may stem from a word recognition score that's disproportionately worse than expected based on hearing loss. This is a red flag. If you have, say you have a small asymmetry in pure tone audiometry, small asymmetry, but a large asymmetry in word recognition scores. So one of those ears is disproportionately worse than expected based on the audiogram. A soft sign would be if you see rollover where you see word recognition scores at a higher level start to decrease so that we have this rollover score. But this has kind of fallen out of favor because it's got poor diagnostic accuracy. What is more important is this table here, these confidence limits by Dubno 95 for how poor is too poor. So you can use this table based on the pure tone average on the left side. So if you have a pure tone average and you're using the NU6 Auditech list, the table may help you decide. So if you have a PTA of, say, PTA of 25 dB, your score should be no worse than 80% correct. If you have a PTA of 50 dB, your score should be no worse than 48% correct. If you have a PTA of 60 dB, your score should be no worse than 36% correct. If it is worse than the lower limits of these 95% confidence limits here, based on your PTA, then that would be a reasonable reason to refer out. Now, if it's disproportionately poor bilaterally, I probably wouldn't refer out for that. That's just age-related auditory neuropathy. But unilaterally, if it's disproportionately poor, then I would refer out for that. The cases of eighth nerve tubers being bilateral are incredibly rare. In theory, you could predict the audibility of the speech intelligibility index obtained and compare that to word recognition scores. That's kind of like what I showed you a moment ago from the Dubno data. If obtained word recognition score is lower than the predicted SII, that would also indicate medical referral. There is one study that looks at the standardized word recognition score and compares it to the SII, but it's difficult to calculate the SII at a high presentation level other than just 55, 65, or 75 dB SPL. Moving on to speech and noise tests. All speech recognition tests up until now have been speech and quiet. However, background noise may be added to emulate a real-world listening environment to offer better face validity. Many patients' chief complaint is listening and background noise. Common speech and noise tests include the hint and the quicksand. There's two components of hearing loss based on the work of Plomp. You have attenuation or an audibility component, represented by changes in pure tone threshold audiometry, speech recognition threshold, speech recognition in quiet. That represents the audibility component, easily predictable from pure tone audiometry. Then you have the distortion component, represented by results from speech recognition, sometimes speech recognition in quiet, and by speech recognition in noise. The distortion component is only represented by speech recognition in quiet when you have very poor speech recognition scores that are disproportionately poor. Then you'd have the distortion component. But we're mainly talking about speech recognition and noise. Cannot be readily predicted from pure tone audiometry. Tests vary from one another in linguistic cues that they offer. Some use words embedded in topic-oriented paragraphs where sentences contain both syntactic and semantic cues. That would be the connected speech test, which is also available in an audio-visual version. You can have words embedded in sentences, so not paragraphs, but sentences, with considerable syntactic and semantic cues. That would be the hint, and more commonly, the BKB SYN. The BKB SYN is more popular nowadays. The hint used to be popular, but it's not anymore. You can use words embedded in sentences with variable syntactic and semantic cues. That would be the SPIN, speech perception and noise test. You can compare high predictability versus low predictability sentences, not commonly used. Here are some sentences examples from the hint. The paint dripped on the ground. A towel fell on the floor. A family likes fish. These are scored all or nothing. Is the sentence correct or incorrect? You're finding the 50% threshold at which they can repeat back the sentences 50% of the time. Here's the quicksand. A white silk jacket goes with any shoes. The child crawled into the dense grass. Footprints showed the path he took up the beach. By far the most popular speech and noise test right now. You're looking at the number of underlying words correct at the different signal-to-noise ratios, going from plus 25 dB down to 0 dB. You put the number correct in the column, you add them up at the end out of 30, and then you subtract 25.5 minus 30, and you get the SNR loss. The SNR loss is how much worse, how much better SNR they need compared with somebody with normal hearing. SNR being signal-to-noise ratio. Now I talked about how pure tone audiometry can predict word recognition in quiet to some extent, but it cannot predict word recognition in noise or speech recognition in noise. And this table shows it. This is from the words and noise test. The words and noise test is just an NU6 with the VA recording with a multi-talker babble, a six-person multi-talker babble, I believe. And for this test here, what it shows is correct word recognition in quiet on the y-axis versus the 50% point, so the performance and noise on the x-axis. So what you can see is if they score really well, near 90 to 100%, if they score really well in quiet, they're probably not doing too bad in noise. But if they do really bad in noise, it's hard to say how they do in quiet. So we can't really predict how they do in noise from how they do in quiet, other than to say if they do well in noise, they probably do well in quiet. But if they do poor in noise, they might do well in quiet, they might not do well in quiet. Moving on to some variations we have for difficult to test children. Usually necessary for children who are under 6 years old or difficult to test older children and adults. Speech is a more salient stimulus than pure tones, so infants may be more responsive to speech testing, so you don't have to use any particular list. For infants, you can use ba 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 ba, ma 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 ma. You can just use nonsense syllables. You want to use monitored live voice for infants for flexibility, and for young children. If you have a 2-year-old, you're probably going to use monitored live voice for using any kind of speech detection threshold or speech recognition threshold. Different approaches and speech materials may be needed for pediatric testing. For speech recognition threshold, if you cannot get the SRT, like with VRA, you have to find an SDT. Yes, it's a lot less informative, especially in the sound field, but it's better than nothing. SRT is an important cross-check for an audiogram. This is especially important for children who are 2, 3, 4 years old for cross-checking their audio, where you can get an SRT, a picture-pointing SRT, and also in cases where it's not possible to get a full audio. And I have had those cases where I could get an SRT, but not conditioned play audiometry. There's a children's subset of spondees, which I already showed earlier on. 20 most easily pictured spondees, which you might use, or you might even just use body parts like show me your nose, show me your mouth, show me your arm, that kind of thing. And then in those cases, they're using verbal or pointing responses when they're real young, when they're 2 or 3 years old. For word recognition testing, usually you do this after you've gotten play audiometry and after you've gotten a speech recognition threshold. If it's a 5 to 6 year old, you can treat them like a little adult. Just do a PBK 50, phonetically balanced, kindergarten word list, 50 word lists. They're just easier words, kind of like a W22 or NU6, but just easier. They're a great list. Now for 3 to 6 years old, this is a harder population to test, but you've got the WIPI, the word intelligibility by picture identification. This is a picture pointing response. It's a closed set test. You're looking for verbal or pointing responses for the WIPI, verbal responses for the PBK 50. I think that's think that's the last point in the slide. Thank you for joining in, and I'll save this and upload it to Blackboard.